Hello, and thank you for joining this Hastings Center event, Reimagining Healthcare Work, Preparing Healthcare Systems, Lessons from the Frontline. Although the audience will not be visible and audible throughout, we encourage participants to please post their questions using the Q&A function in Zoom. This webinar is being recorded and will be posted on the Hastings Center website tomorrow. It is now my pleasure to introduce Dr. Nancy Berlinger, Senior Research Scholar at the Hastings Center.
Thank you, Danny. Thank you, colleagues, and thank you, audience members, for coming out today. So what we're going to be doing here is we're going to hear some brief research presentations. Then we're going to have a discussion, and then we're going to turn it over to you. And I'm going to tell you in a moment the 3 different ways that you, the audience, can interact with us in real time. So responding to the COVID-19 pandemic demanded remarkable creativity, innovation, and change from clinicians, from doctors, from nurses, respiratory therapists, physician assistants, and many, many other people who work in clinical teams. How can we leverage the insights and lessons learned from working during COVID to transform healthcare work going forward? And how can we create meaningful change in a broken American healthcare system? As I mentioned, this webinar will feature insights from 2 studies of healthcare work during the pandemic. Then the researchers will be joined by a healthcare journalist and a clinical ethicist, both of whom are also clinicians, for a discussion about the future of healthcare work, including real-world steps healthcare organizations can take to better support their workers. So I'm very honored to introduce today's participants, and everybody, you can turn your cameras on. Great. Mara Buchbinder is professor and vice chair of social medicine at the University of North Carolina, Chapel Hill, where she directs the study to examine physicians' pandemic stress, known as STEPS. Neelima Navoori is assistant professor of medicine and global health at Duke University. Dhruv Khullar is assistant professor of medicine and population health sciences at Weill Cornell Medicine in New York City and a contributing writer on medicine, healthcare, and politics at The New Yorker. Amy Milliken is associate professor of the practice at Connell School of Nursing at Boston College. A full disclosure, I'm a member of the STEPS research team, and Amy and Dhruv are project advisors to our team. We also have very strong North Carolina representation because Neelima's study is based at Duke and Mara's study is based at UNC-Chapel Hill, but that's just a happy coincidence. So, as I mentioned, audience members, there are 3 ways you can interact with us today. First, Danny Pasha, our host, will see your questions as they're posted in the Q&A. She may respond to some questions directly. For example, you'll see that she'll drop links to the publications we mentioned in the Q&A. And if you don't see the first link because it's gotten sort of buried, you can just ask for it again and she'll drop it in. You can post your questions for us in the Q&A, and we'll get to as many questions as we can at the end of the session. And Danny will also forward frequently mentioned issues that are surfacing in Q&A to me so I can weave these into our discussion. So if you hear some familiar sounding language, it's probably because I'm trying to weave your question or comment into my questions to the discussants. Okay. So now Mara and Neelima will provide brief overviews of their research findings from studies of frontline physicians during the pandemic, just the highlights, with attention to lessons going forward. So this will support our discussion, and you don't have to have read the publications in order to get a good grip of their findings. So now I'm going to turn it over first to Mara and then to Neelima.
Thank you so much, Nancy. I'm just going to share my screen. Let's see. Okay. Great. And I'm really just delighted to be here today and to be able to share some STEPS findings with you. So I direct the STEPS project. It is funded by the Greenwell Foundation and the National Institute for Occupational Safety and Health. I want to start by acknowledging my team, which includes Nancy, as well as Tanya Jenkins and John Staley at UNC as co-investigators, and several research assistants and local consultants in the cities that we worked in. STEPS developed out of a concern for the significant work-related stressors facing frontline physicians early in the COVID-19 pandemic. And our key question for both of these studies was, what are the structural factors shaping frontline physicians' stress during the COVID-19 pandemic? The conceptual model guiding our research was adapted from a model proposed by the 2019 National Academies of Medicine study on clinician burnout. And the NAM model explicitly called for more research on systems factors. So it depicts frontline care delivery as shaped by organizational and external environmental factors, which interact to shape clinician outcomes such as burnout and professional well-being, as well as patient outcomes. And our goal with this study was to assess how differences in each of these nested circles or layers mediate the stress and well-being of individual physicians. Overall, the project has a comparative qualitative design aimed at assessing physicians from 4 US cities, and they are New York, New Orleans, Los Angeles, and Miami, who cared for hospitalized COVID-19 patients during the pandemic. Our goal with this comparative design was to understand how differences in local politics and hospital funding structure mediate the ways that individual physicians experience this crisis. So we conducted semi-structured qualitative interviews over Zoom, and we asked questions about personal background, onset of the COVID-19 crisis, institutional practices and policies, working during the pandemic, personal well-being during the pandemic. We recruited a diverse sample of attending physicians and fellows, balanced for participant demographics, specialties, and hospital type. And the final sample included 145 participants. Most were under the age of 50, just over a half were women, 70% were white, and 90% were non-Hispanic. Their mean number of years of experience was 10, and they worked in a total of 44 distinct hospitals across the 4 cities, with diverse funding structure, size, and patient populations. And a third of them worked in safety net hospitals as well. So our main study finding was that physicians reported stressors really at every level of our conceptual model. And we reported these in our article published last fall in the Journal of General Internal Medicine. So these stressors included individual level stressors like age and life stage, work experience, concerns about viral transmission, and strained personal relationships. Organizational level stressors, including staffing constraints, resource disparities, organizational policies, particularly those governing visitation, and perceived poor leadership. And at the professional level, participants reported concerns with informal rationing and medical uncertainty. Finally, at the societal level, stressors included state and federal government responses and messaging, the politicization of COVID-19, and societal inequalities. So taken together, these findings suggest that individual factors like resilience cannot account for how physicians cope with work-related stress. Understanding stress and burnout really demands a systems perspective. Some participants in our study would have been able to navigate the onslaught of stressors more effectively if they had only had a more supportive institutional environment, or if professional cultures were not undermining their sense of professional efficacy, or if they weren't confronted on a daily basis with patients who challenged the reality of COVID-19. So our interview findings reflect interactions between health systems, work environments, professional norms, and individual well-being. One of the products of the Greenwall study was a set of recommendations for chief wellness officers and other similarly positioned individuals. And the chief wellness officer is a hospital executive level position responsible for championing the well-being of hospital-based clinicians. We decided to target these recommendations to chief wellness officers because we thought they would be best positioned to respond to our study findings and implement systems change for addressing clinician stress and burnout. And we developed recommendations in 6 domains, which I'll run through now. To address intensified feelings of powerlessness, we recommended that chief wellness officers commit to learning from physicians about institutional factors that impede their ability to provide good care through regularly scheduled paid feedback sessions that include leadership, and that they promote quality improvement research on workplace conditions that impede good care. To address institutional policies that serve as a source of stress, our recommendations were to solicit frontline clinicians' input throughout the development and implementation of new policies and processes, and that they request feedback from unit leaders regarding the impacts of policy changes and bring conflicts between patient care policies and clinicians' perceptions of good care to leadership attention. To address physicians' sense of complicity and perpetuating injustice stemming from inequities in care, our recommendations are to recognize feelings of complicity and injustice to patients as corrosive to well-being, and to collaborate with diversity, equity, and inclusion administrators to incorporate DEI priorities into wellness programming. To address rising mistrust of physicians, our recommendations were to acknowledge mistrust as a societal phenomenon that will continue to affect clinical encounters, and to contribute to wider institutional efforts to build trust with patient populations, and to help frontline clinicians respond to misinformation and mistrust. To acknowledge the helpful role of workarounds during the pandemic, our recommendations were to recognize improvised practices or workarounds, develop to manage new or intensified work challenges under pandemic and everyday conditions, and then to study these practices and their outcomes as potential sources of practice innovation. And finally, to harness the strengths of supportive colleagues during and throughout the pandemic, our recommendations are to create opportunities for clinicians to explore causes of work-related stress and to share promising practices with and between units, and to create leadership training and mentoring opportunities for unit leaders to cultivate unit-level cultures of inclusion, well-being, and advocacy for improvements. And it's worth noting, I think, that while the pandemic was a catalyst for all of these recommendations, all of them have applications well beyond the pandemic. You can read more about these recommendations in our final report, which is linked here, and I think we can put a link for that in the chat as well. And with that, I will turn it over to Neelima.
Thanks so much, Mara. That was terrific. And again, yes, we'll be dropping the links in the chat, and the STEPS website has other publications and information as well as about the project. And Neelima, feel free as well, if there are additional links to your project or other publications, feel free to share. Okay, so over to you.
All right, if I can figure out how to unmute and get everything working. Is that the right? Hopefully you can see the right screen there. So thanks so much for the introduction and having me here. It really is an honor and pleasure to be here, and really excited to sort of share a little bit about our ethnographic study of healthcare workers that we conducted during the pandemic and some of the key takeaways that we are left with. So to begin, I must first fully acknowledge the team effort that it took to complete this work and the ways in which our positionalities influence some of our analytics. So myself, Dr. Peter Hewson, who's pictured at the top left, and Dr. Charles Hargett, who's pictured at the bottom left, are all pulmonary and critical care physicians with faculty experience ranging from between 3 to 30 years. We were actively working as both clinicians and ethnographers throughout the study period, caring for COVID and non-COVID ICU patients alongside many of the people we interviewed. This allowed us to bear witness, I think, to how people grappled with the constantly changing conditions and how the use of space and interactions with other workers sort of changed over time during the pandemic. Harris Solomon, who's pictured at the top right, is a medical anthropologist with extensive previous experience in intensive care settings. He participated in most of the interviews, but did not conduct any of the participant observation given visitor restrictions. And so his perspective was often a counterbalance and allowed us to widen our analytic lenses. We conducted a total of 69 interviews with 57 participants, 12 of whom we interviewed twice. And we purposely tried to capture a wide range of job roles within the ICU. So we had relatively equal numbers of nurses and physicians, the latter at different stages of training, so residents and attendings and fellows, as well as 6 respiratory therapists and 6 pharmacy, supply chain, and environmental service workers. Notably, most of our interviewees self-identified as white, which I think sort of limits some of the generalizability, but hopefully is still a full analytic. So we started our study in the summer of 2020, when the predominant stories about healthcare workers really centered on their heroism in the face of uncertainty and risk. We continued interviews through December of 2021, and along the way, both the narratives we heard and the ones that were shared across social media and the press shifted to stories about exhaustion, burnout, and moral injury or distress. As I'm sure you all remember, or perhaps you want to or have chosen to forget, a lot happened and changed over those 2 years. And in terms of ICU work and labor, we both experienced and watched how healthcare workers' roles and occupational experiences were transformed. We settled on the term distressed work to try to convey the struggle and inseparability of moral commitments to care work, which many individuals shared with us, and then the strain of the everyday conditions they were subject to. We also felt the term opened up the possibility for positive changes, and that identifying the ways in which work becomes distressed allows us to also identify ways to remedy it. So the foundation of the distressed work analytic is that study participants believe that a fundamental driver of their choice to work in healthcare, and critical care specifically, is a deeply held commitment to care for people during the most difficult times of their lives. They emphasize that caring for COVID-19 patients is their job and professional duty, that they signed up for this and it was just doing their job. They were fulfilling a duty even if it affected them and sort of regardless of how it affected them. But at the same time, many workers also described a critical tension between this feeling. While ICU work was their calling, it was also a means of compensation and their livelihoods. And as they experienced how spatial divisions affected how others performed their duties, they began to question why there were differential experiences. So for example, when a surgical subspecialty was consulted for a patient with a recurrent nosebleed, one of the nurses noted that subspecialty wouldn't enter the room to reassess the patient, citing they were limiting COVID exposure. But meanwhile, the other nurse was spending, or the nurse herself was spending hours a day in the room. And similar stories with other specialties or ancillary services sort of abounded. These moral imperatives were pitted against the idea of chronic distress work, which our participants detailed in two general themes. The first was that as the pandemic waxed on, our respondents increasingly shared feelings of isolation, alienation, exhaustion, frustration, and connected all of these emotions to a particular sense of loss of unit cohesion. They were stuck alone in rooms for hours on end, could no longer sit next to coworkers during their lunch hour or in the break room, and that was seen as a sign of resilience building and relationship development. So it was distressing to them that that was something that they had lost. Even at home, they had to isolate from their partners and their children, especially among those who had family members who were at high risk for severe COVID. And the isolation followed them from work to home and even to sort of social settings, such as the grocery store. And one individual narrated going to the store after work in their scrubs, and the grocery clerk didn't want, her groceries on the counter. And so collectively, these feelings and the attendant sense of loss were associated with a significant amount of emotional distress and a sense of being at work, even when not at work. The second theme of chronic distressed work was around visitation and end-of-life policies. So pre-COVID, there was generally really no limitation, at least at our hospital, on the number of visitors a patient could have at a given time or the amount of time they could spend with the patient. So ICU workers were really accustomed to having family members sleeping in the room and to extended visits from close family and friends. But with COVID came restrictions on visitors with initially no visitation allowed. And even though restrictions were eased and redeployed in different phases, for the most part during our study, COVID patients could only have visitors for goals of care conversations or at the end of life. And even then, it could only be 2 to 4 family members, which was really distressing for both families and the people taking care of them, who often had multiple family members who would want to be there more than 4. These policies were seen as draconian and bordering on immoral by our participants. It also kept our participants up at night, especially among many of those who could relate to the experiences of being a family member of a critically ill patient. So one physician shared with us that it required them to disengage from their emotions to do their job. And this was seen as a depersonalization of their roles as healthcare workers. So collectively, distressed work entails the tension between the shifting ways that moral relations healthcare workers have to work to their work and work structures and practices, and then the ways that institutions and healthcare systems attend to those moral relations. It leaves us with a lot of unanswered questions about this time that we are calling the next normal. And I think, some of these include, is distressed work actually the next normal? Is this what we can expect going forward? And if so, what can we expect from healthcare workers as we go forward in the institutions and systems in which they work? And I think if there's one big takeaway from our work, it's that the answers to this really has to come from the healthcare workers themselves. And the institutions and healthcare systems cannot employ sort of a top-down approach in addressing this crisis of work. So with that, look forward to hearing your questions.
Thank you so much, Neelima. That was great. When we were very proud, I should add, that you published your paper in the Hastings Center report. So thank you. That we were seriously, when we saw the paper, it was wonderful. When we saw that, it was like, yay. Okay, so now what we're going to do is we have plenty of time for discussion, which is terrific. And I wanted to just let our audience know that I conferred with our panelists about the questions, because they had a chance to look at each other's work and so on. So just think, what's the thing you would love, now you've got the author in the room, what would you love to ask? So I'm going to start with Amy. You started your career as an ICU nurse. You have worked in hospital settings, especially in the Boston area. You've worked as a clinical ethicist, as a nurse scientist, and now a nursing educator. What resonated with you as a practitioner or in your other roles about the Neelima and her team's amazing research that was carried out by working ICU clinicians? That was really something to see that you were doing this ethnography in real time.
Thanks, Nancy. I first of all want to thank Neelima for sharing this incredible work. One of the things that resonated with me so much was how skillfully you told this story that so many of us experienced in so many different ways. And yet I still struggle to put words to it. So I think for me, that was one of the things that stuck with me most. As Nancy said, I started my career as an ICU nurse, and it was the experience of moral distress at the bedside pre-COVID, long before COVID, that drew me to ethics. And I didn't have the language at the time to sort of talk about what I was experiencing and to add the sort of ethical framing to it. And it wasn't until my graduate studies that I was sort of exposed to this entire body of literature. And that's really what drew me to clinical ethics. And so I think we know, and your team just does such a good job of telling this story, that many sources of moral distress, to use that sort of more traditional framing of the concept, existed long before COVID, right? But what COVID did was it sort of magnified existing sources of moral distress. So think about conflicts around end-of-life care, inequitable care, disparate care disproportionately impacting our most vulnerable populations, right? COVID magnified those things and then added an additional layer of new stressors that we hadn't experienced. And in particular, I think one of the things that's interesting when you think about moral distress, distressed work, and the overlay of COVID is that there was this new layer of uncertainty that got added. And when we typically think about moral distress, we think about the clinician knowing the right thing to do, but being unable to do it. And certainly I had that experience as a clinical ethicist working through COVID, but more often than not, for me, the distress came from the fact that we actually didn't know what to do. We knew that we couldn't provide the care that we're used to providing, but we didn't know what the alternative looked like. And so that's where I really like this reframe of distressed work, because I do think our experience is sort of more all-encompassing than the traditional framing of moral distress. And so I really like this sort of more all-encompassing framework that you've added. And then the last thing I'll say, sort of the third thing I really appreciated from the work, were the questions that you left us with. And these are questions that I've sort of been grappling about in my own work, which are sort of, how do we think about the sustainability of the healthcare workforce now that we're sort of in a post-COVID not implying that COVID is gone, but implying we live in a society where COVID is a thing that exists. We're in sort of this post-COVID world. And although we're not necessarily being inundated with COVID patients, barging through the doors left and right, the consequences of the last 3 years are still very real and having real impacts on our healthcare workforce. So how do we think about, and Mara, I think your work speaks to this really well too, how do we think about sort of caring for our carers? And the parallel question, this idea of healthcare providers coming to healthcare because it's a calling, right? You often hear this with physicians. I hear it all the time with nurses and my nursing students, right? This is my calling. This is what I was meant to do. And on the one hand, that's wonderful because it provides a sense of fulfillment and gratification in the work that we do. On the other hand, there's a very fine line where it sort of sets us up for martyrdom, right? So how do we think about the extent of our moral obligations in healthcare? What degree of sort of self-sacrifice should be expected? What are our moral obligations? And then what becomes sort of beyond a moral obligation? What becomes sort of a supererogatory obligation, or a supererogatory act, I should say. So I just love the fact that you were able to tell this story and then sort of tee us up with these questions that I think are the most pressing ethical questions of our time.
Thank you, Amy. I was also reminded along the same lines of, Dhruv was also working as a hospitalist during the pandemic here in New York City, where I live. And I remember early on, I couldn't even figure out when you were writing, Dhruv, because you had something like every week in the New Yorker, and you were working, not usual shifts at the hospital. And I remember very early on in one of your early dispatches, you said something like, I have never seen people take on completely new procedures so quickly. And I think you even said, like, I'm proud of us. Like, look at how quickly we have to pivot. This is crazy, And I wonder if those emotions that Amy was talking about, that feeling of we don't know what to do, but we're going to have to figure it out, that sort of clinical pragmatism that some people talk about, how that struck you and how that could, as Nilima talked about, over time, become a source of stress, the continual pivots.
Yeah, it's a great question. And thank you for that. And I agree with so much of what Amy just shared. I think during that period, thinking back on it, it was really a time that was incredibly stressful and challenging, but there was also a sense of, this camaraderie that I had not experienced before. I mean, everyone from medical students, chaplains, nurses, social workers, physicians of different specialties, outpatient physicians, everyone was just willing to do whatever it took to care for patients. And so there was this tremendous outpouring of kind of professionalism that I really appreciated. Now, some of that was also supported by the fact that a lot of requirements that are often placed on people went by the wayside. And so a lot of documentation requirements, a lot of the administrative burden, a lot of the things that we do that are not central to the work that most of us got into this for, those were not imposed. And so there was this kind of dual, professional obligation, but also this waning of administrative burden. And I think that's one thing that I really kind of appreciated in both presentations was taking the system level view. I think throughout my training or whenever there's been stressful experiences clinically, one of the things that bothers me most is when people offer things like yoga or mindfulness or come around with candy as if those things, they may be well-intentioned, but they could alleviate some of the deeper stressors that a lot of clinicians feel when they go to work. And so, who should these kind of recommendations go to? I mean, I think, Mara identified chief wellness officers, and I think hospital administrators are kind of a big part of this. And I think that's a very appropriate kind of recommendation. One question that it leaves me with is, how much power do chief wellness officers have to change some of the things within their health systems? I mean, I imagine there's a lot of heterogeneity across systems. In some systems, they may actually have a lot of influence on what happens, and other systems probably less so. But when very tactical things happen, like your computer is broken, or you don't have enough chairs or desks, or there are certain administrative burdens, minimizing documentation requirements, and really, providing higher staffing levels in a lot of these units and settings where a lot of the stress comes from the fact that you feel like you don't have the necessary resources, in terms of personnel or otherwise, to provide the type of care that you want for people. That's incredibly stressful. And so, I think there is certainly kind of softer cultural, environmental things that can help people feel respected and can help people feel like they belong to an organization. But there's also very tactical things that I think when those are not taken care of month after month and year after year, I think sometimes the words feel empty. And so one of the things that I appreciated about the discussion so far is taking both the personal kind of individual view, but really thinking very deeply about what we can do at the system level to support clinicians.
Thanks, Dhruv. And that ties very well into the next question, which is going to be directed at Mara. Part of the STEPS research was funded by the National Institute for Occupational Health and Safety, NIOSH, which isn't part of NIH, it's part of CDC. What do you think is gained by looking at healthcare work from the perspective of worker health or safety? Because NIOSH does research on all sorts of occupations. It's not tied to the fact of a patient care relationship. Rather than seeing healthcare work as special or assuming healthcare workers are healers who can heal themselves, maybe with, as Dhruv said, some yoga, some deep breathing, but, you'll basically be fine. Or it's your problem, if you're just not getting it together. So I just wonder, how has that worker lens, influenced, I don't want to say our thinking, your thinking, but what does it bring that seems a little different from the wellness lens that might get more toward these tactical workforce issues?
Yeah, thanks for that, Nancy. I think one of the things that's been very valuable to me as my thinking has evolved on this topic is that I think it's productive to move away from a mental health lens in thinking about clinician burnout and well-being, because that can be so stigmatizing. And it can really, even though there's been a lot of work to sort of try to change this, there's still a tendency to kind of to blame people in some respect, or to hold them responsible for mental distress and mental health problems. And I think that the NIOSH lens really brings a focus not just on distress as located within an individual worker, but also in thinking about the whole work environment and really locating that distress within the broader work environment. And so what does that do? It really helps us to start to imagine different kinds of solutions to these problems. So Dhruv, I think, started to touch on this really nicely in his remarks, but instead of thinking about things like yoga or hypnotherapy or mindfulness to kind of alleviate some of this stress, we might think about organizational level interventions like flexible scheduling and different staffing models. These are some of the things that participants in our study brought up again and again as really having a huge impact on their stress levels. And we saw as well in our data that that organizational culture really had a huge protective role to play with individual clinician well-being. So if in places where there was transparent communication from leaders, in places where there was really strong camaraderie among colleagues and teams, it had a protective effect and it made a difference. And so I think the NIOSH lens, this sort of broader understanding of occupational health, helps us to kind of look at this broader system and not just kind of think in terms of individual workers with depression or burnout or sort of this very kind of decontextualized symptomatology.
Thanks, Mara. Any other points before we that to follow up on this sort of the idea of resetting the conversation away from the mental health issue, the burnout issue, or the going to that this is an individual problem of stress that can be resolved through individual solutions, to a focus on work and workers? Any other thoughts on that? Even about how one thinks it might have traction? Amy.
Yeah, I mean, I think one of the things that's really powerful about this framing is that in healthcare, the sort of OSHA, NIOSH worker safety frame is a very familiar one to us, right? Like we all take the annual trainings about workplace safety, and you all have to have your occupational health visits before you start your job. You know what to do if you get a needle stick, you know who to call, the reporting requirements, that sort of thing. So those are very familiar ways of looking at worker safety in the healthcare system. It hasn't been applied to these other issues of ethics. And people in ethics pre-COVID and since COVID have been saying, look, the system is broken. Moral distress is not a problem of me as the individual. It's a problem of the system. And it often, I think, feels like those calls go unheard. And so I think one of the sort of really innovative things about this framing is that it really does call us to look at the worker safety framing, look at the OSHA framing. What can this institution do to protect you as the worker? Workplace stress, distressed work, this is a hazard of the job, and we can't allow you to sort of do this work without the necessary protections. And so I don't necessarily think we know what all of those protections might look like but I think this framing again allows us to take a different lens to look at the situation, which I hope will sort of gain more traction than other approaches have historically.
Thanks, Amy. You know, it occurs to me that there could be some pushback on this proposed reset. And from healthcare workers themselves who may say, well, look, I think of this as a vocation, or this is special. We should make a claim that this is special. This is a helping profession. This is a healing profession. Are you telling me I would have to give that up and just be a worker? You know, I actually, in my writing on workarounds, I do use the word worker because workarounds occur at so many levels. It's not like there's special ones that just occur because they're all about your relationship to power. But I do wonder if that's part of what one would have to say. We're not taking something away from what one gets out of being a doctor or a nurse or a team member. But there are things about the nature of employment that might be best addressed by thinking about this as a labor force, or not just saying, oh, labor issues are for the unionized workers, not for all of the workers, which is a great way to pit doctors and nurses against each other, of course. So food for thought there. I should add, we had questions that came up in the chat. Did either of the studies, I know the answer on one of these, did either of the studies include social workers or chaplains? So this would be Nilima, did this include those members of the team in the ICU?
Yeah, so chaplains and social workers are definitely part of our care teams, but we didn't actually, we weren't able to recruit any of them as participants. And so their sort of experiences aren't reflected in our findings, unfortunately.
So that's part of the challenge of all research, and also real-time research, is who's actually available to talk with you. And of course, some professions moved out of their normal workspaces, because if you were primarily caring for families who weren't present, then you had to figure out a different way to do your work. We're going to put in the Q&A, for those of you who are particularly interested in research on COVID and other experiences of healthcare chaplains, and possibly also of other behavioral and social-oriented professions, the Chaplaincy Innovation Lab at Brandeis is a great research hub on spiritual care research. So you might want to check that out. They would likely have a research archive there. So now I'm going to turn, before we turn to audience questions, I'm going to turn back to Dhruv in your role as a journalist. Last week, you wrote in the New Yorker that pandemic policy also contained flashes of what is possible. Real achievements in making life easier for millions of people came as the result of the choices we made. For example, the child poverty rate in the US fell in 2021 due to the impact of the child tax credits that were part of pandemic relief. Low-income parents had more money for the basics: food, rent, utilities, clothing. This also is part of pandemic research, that we were able to measure the benefit of these innovations. Food insecurity fell due to the expansion of the food stamps program. people who have had secure Medicaid health insurance for the past few years are now starting to be dropped because emergency funding to the states is being rolled back. But there were people who were healthcare insecure who had high quality health insurance, perhaps for the first time in their lives. So my question to you after all that doom is, do you see anything affirmative on the horizon? Is there any healthcare system or state health department or federal agency whose new normal is to retain and build on progress made during this public health emergency in the direction of health and well-being for all, or at least more people in this country?
Yeah, it's such a good question. And, part of the point of the article was to show that, this has been a period of tremendous turmoil, obviously. And in so many ways, we've come up short as a country in terms of addressing the pandemic. But I wanted to try to flip the lens and show that there was real progress that occurred because of social policy choices. And so, as you say, rates of food insecurity dropped to their lowest level in history since we've been starting to keep track. Rates of childhood poverty dropped to the lowest level in history. The country's uninsurance rate dropped also to the lowest level in history, to 8%. And what is so kind of disheartening about that progress in a way is that it's all going back in the other direction now. The policies that we instituted during the pandemic to help people with their basic needs, whether it's food, whether it's shelter, whether it's stable health coverage, those are things that we are now reversing also because of choices that we are making. And so, I think a lot about this idea of the liminal state. And so there's an old normal, there's this liminal state in the middle where there's chaos and it's challenging and it's uncertain. But then you get to choose the new normal or the next normal, as Neelima said. And so, what I'm trying to draw attention to is that we can make choices that make people's lives easier going forward. Now, I think there are some flashes of progress and things that seem promising to me. Things like telehealth expansion. So part of that is being rolled back, but not all of it. A lot of the telehealth flexibilities that were made available during the pandemic, they're at least being extended for another year or so until the end of 2024. And then Congress will make a decision on how much to continue versus not continue. And so that's an example of continuing some positive changes during the pandemic. As the COVID public health emergency has come to an end a week ago today now, there are ways in which it's going to be harder for people to access testing and treatments and vaccines. But the Biden administration has rolled out what's called the Bridge program. And on the Bridge program, uninsured individuals will be able to have access to free vaccines and free therapeutics like Paxlovid, at least for another year. Who knows what happens after that when the stockpile runs out. But that's a way in which it's softening the blow of the end of the COVID-19 public health emergency. When it comes to Medicaid unwinding, that is a huge issue. And, by some estimates, something like 15 million people might lose Medicaid coverage over the next year or so. Some states are, I think, working harder than others to confirm eligibility, to make those determinations. Some have announced that it'll take at least a year for them to really do their due diligence and try to figure out who's still eligible. And so you could envision a system that doesn't have as much administrative churn in it. Other states have already kicked off thousands of people, and there's obviously discussion at the national level about work requirements for the Medicaid program. And so that's another disheartening development. I think more generally, some of this points to the idea that both, in a clinical setting, we've talked about administrative burden, but for people trying to access the safety net in the United States, there's a tremendous amount of sludge. There's a tremendous amount of challenge with paperwork. People who are eligible for programs don't always take advantage of them. So if you think about Medicaid, if you think about the Earned Income Tax Credit, you think about the SNAP program, the WIC program, all these things require a lot of cognitive resources and time resources, and sometimes even financial resources to access programs that can make life easier for people. And so I think there's at least a recognition that there are things we can do, like automatic eligibility in the case of Medicaid that smooths that for some people. So in a way, I'm hopeful that we can develop a state, a next normal that feels less precarious for people than the old normal did. But I think we're still in that transitional state, and it's up to us to kind of advocate for those types of developments.
Thanks, Dhruv. Yeah, so there's no magical solution, which in a way is sort of good to hear that directly from someone who's part of whose job is to look at everything that's going on in this country and in other countries. You've reported from India as well. Because sometimes we can get attached to the idea that there's a magical state or a magical country, usually in Northern Europe, where they do it right and there's no problems. And if you talk to one person in that place, they'll be like, oh no, let me tell you about our problems, because it's reality. I do find, though, some of my work involves lessons from COVID that involve the needs of older adults who are the highest risk group with respect to COVID mortality and morbidity. And it was the lessons that focused on their housing and their environment. And so we published a report last year, and we have a follow-on project now. And it involves a number of policymakers. And some of the hope that I get is from them, because they are taking seriously some of the things that you talked about, saying, wow, it was so much better when we had that temporary lifting of compliance and red tape. Why do we want to put back some of these live signature requirements or these multiple pieces of paper when we are talking about older people or disabled people, and we've made the transition to telehealth? Why can't we do that with their paperwork so that they have the housing benefits or the utility benefits or whatever it may be? Why do we tolerate these mismatches in eligibility and just talk about people being trapped in the gap when we could fix it? We just have to get people from different parts of the system together. We have to get housing people together with health people rather than just bemoan the fact that other people don't understand what's going on. But it takes real work and just real engagement with policymakers being willing to spend time on this. But you do hear these heartening bits of progress that people are doing in different sectors. It takes, if you just get bummed out looking at the healthcare system, like, well, there's other places where health and well-being is happening in American life. So we have time for some questions now. So I'm going to jump over to that. So there are some insights here that are really just reinforcing what we've just heard. Hospital administrators do not seem to share the insights presented here. They just suggest counseling and offer meals and suites. So I think, the fact that clinicians have seen the limits of this now is something that is really when we talk about engaging leadership, we have to get this up the line. Some have suggested, were there lessons from humanitarian work or from working in those zones that can be carried forward into healthcare systems? This is a question that I think Amy might be interested in, is there any capacity for hospital ethics resources, whether it's clinical ethics, whether it is ethics committees, to be in any way constructive in the kind of system level change that is needed in healthcare systems? Or do they just operate in a different part of the system? You've run the ethics department at a major metropolitan hospital that was in the first wave of the pandemic. What are your thoughts on what ethics can do, institutionalized ethics can do, and what it just is not set up to do?
Yeah, no, it's a great question. And I mean, I think a lot of our work in those early phases of the pandemic, and this is part of what I've published about, it was twofold. One was, oh dear, we're going to probably need to put together a crisis standards of care protocol. What do we do about that? And, the sort of many iterations of successes and failures in that realm. So from my perspective, that is sort of more of an organizational ethics role that ethics committees can sort of step into, being attuned to both the needs of the organization, but also the needs of the community. The second role was really boots on the ground, dealing with ethical crises that came up. So what do we do for this particular patient? what do we do if tomorrow we run out of ventilators? Do we give this one particular patient the vent, or do we give a different particular patient the vent? So that is more of the traditional role of clinical ethics, dealing with those one-on-one ethics consultations. In this phase of things, I think there absolutely is a role for that sort of broader organizational ethics lens to be applied to things. The challenge, I think, and this is certainly true in Boston, I think true in most institutions throughout the United States, really becomes resources. Many hospitals don't have an ethicist who's even paid to do ethics. It tends to be someone who's working full-time doing something else, who, like, out of the goodness of their heart, helps with ethical challenges. And from my perspective, that's a fault of our systems. We're not investing in the resources that really could help us think through these system level problems and weigh benefits and burdens, think about trade-offs, think about values and the role of values in these decisions. So I absolutely think the framing should be a component of these sort of problem-solving strategies. And perhaps one of the systems fixes is to invest more in people who have training in ethics, so that we can develop approaches that are sort of sensitive to these values.
Thanks, Amy. Again, some more comments, and then I'm going to turn to Mara. Sometimes the candy treats seem to trivialize our ongoing stress, made some of us feel that administrators really, truly had no clues about the depths of our true ongoing stress. Imagine if you took that out to another setting and you knew somebody was going through something terrible and you just like kept giving them M&Ms or something like that. They might be like, that's nice, but it's not really getting at the challenge here. And because
Nancy, what's so insulting is that the treats aren't even usually that good. Like, if they're really good treats, I would say maybe, but it is usually like M&Ms or something like that.
Yeah, exactly. Like if it was like an artisanal donut, but if it's
just we're
that,
not getting like Google level, kale and whatever else they get over there.
Exactly. So yeah, even when you can see the budget cutting right there, it's a problem. Mara, you're an anthropologist, and you might want to very briefly describe what an anthropologist does in healthcare. Nilima, your study included an anthropologist on your team. What are the implications of all of this research for going forward for how you study healthcare work, how you study these environments? Do you think that this will change some assumptions about how you view how professions that study the tribe of medicine, what you assume about this, or things that, I didn't notice that before. I'm going to pay much closer attention to that now.
Yeah, I was going to say that Nilima might be able to speak to what an anthropologist does in healthcare even better than I can at this point, after working on this study that she did with Harris. But anthropologists are fundamentally interested in culture. And so the culture that I study is the culture of medicine. And, we teach our medical students here at UNC that medicine has culture just as, exotic, faraway places have culture, right? So there are norms and beliefs and pattern practices and all of these implicit systems in place that govern behavior on the ground. And so part of what we were trying to do in this study is really sort of understand how medical culture was being challenged by the pandemic, but also how it was giving. So one thing, for example, about that is that one of the biggest findings of our work was that and I think this overlaps with Nilima's work as well, one of the biggest sources of distress for healthcare workers was visitation restrictions, and the fact that family members could not be present with patients at the bedside as they were dying, oftentimes, particularly in the very beginning of the pandemic. And why was that challenging? Because there are many things that families do that sort of help keep healthcare work moving along as it should. And when that system is broken, Providers have to find other ways of communicating with family members. They have to call them. Those conversations might not go as well as they would if they're in the same room. And so there were all these ways in which these cultural routines were disrupted by the pandemic. And that's part of what we were documenting. But I think also moving forward, there's sort of this opportunity for culture change and culture shift. And I think Dhruv was alluding to some of this in his final remarks, and we need to sort of think about where are the spaces of opportunity for kind of building on workarounds and building on these glimmers of a different way in which things might be, right? Really rebuilding organizational cultures and trying to mobilize them around some of the positive things that we saw emerging during the pandemic, like those strongly networked teams and like the sense of solidarity and support. So I think that if we want to tackle this problem of clinician well-being and burnout, it really it needs to be from an interdisciplinary perspective. And I think that social scientists, including anthropologists, have a lot to offer that conversation. And I would add historians to that as well, because I think that that history repeats itself and the rest of us forget. And historians are really good at pointing out for us, how some of these patterns are things that we've seen before.
Yeah, and I'll just follow on that. I mean, I think a couple of points, Mara. Yeah, I think having Harris and an anthropologist involved was critical for us to be able to really sort of take ourselves out of the position of sort of being clinicians working during the pandemic and taking care of this and experiencing it, to really sort of take a step back and sort of bring some analytic lenses that we hadn't thought about around labor and space and things like that to what these experiences were and what our colleagues were experiencing. And so I think being able to collaborate in that way was fundamentally critical. And then I think there's a question in the chat, which is really important to think about sort of how do we incentivize like the systems to actually respond to this and work on this. And that's an excellent question that I wish I had all the answers to, but I don't. I think one important part of this is to recognize, we talked a little bit about this in the paper in Hastings Center, was that, we had sort of what I call a mass exodus of the workforce. We had, I think, nearly 30 nurses who left our ICU over the couple of years that we were doing the study. And, I'm sure you have all seen the articles or covered this yourselves about sort of how many people were leaving the workforce during the pandemic. And I think, I'm a little bit cynical about systems change and sort of what incentivizes them. But, I think retention is probably a really critical part. I want to believe that they are invested in worker well-being and safety and contentment in their jobs. But in reality, if the main incentive is sort of, dollars and cents and things like that, it really is about like, how do you retain staff? How do you keep people in the workforce? Hospitals spent millions of dollars on travel nurses and things like that to sort of fill these gaps. And, as Mara said, like history does repeat itself and we will face something like this similarly. And I think investing in sort of ways to avoid that sort of exodus during times of crisis or during times of strain, which I think are going to become increasingly common, is going to be really important.
Thank you, Nilima. We have such a short period of time, so I just want to call our attention to a couple of things that are in the Q&A. One is that one of our attendees is a extremely distinguished chaplaincy researcher, George Fichette, a former colleague of mine, who has posted a couple of important links, a summary of the chaplain's experiences during COVID. And that link is posted. And there's also a book called Transforming Chaplaincy. There's actually, that's a source, an organization, which has published an ebook with journals chaplains wrote about their own work during the pandemic. So rich resource for narrative ethics, and also good if we want to go directly to the chaplain's experiences. Because as Mara said, this is now where the history archive of these experiences has been building for the past 3 years. I remember one historian who of the Spanish flu after World War I said, we sort of forgot about that. It went down the memory hole. It got attached to the war. And so it'll be interesting to see how the memory of the pandemic is even carried forward. This link will be posted most likely tomorrow. We have some little bit of work to do on it before it goes live, but then it will be fully accessible on the Hastings Center's website. And with that, I will turn us back over to Danny, who will close this webinar. But thank you all so much for being here today.
Thank you again for joining this Hastings Center event. And like Nancy said, this recording will be fully available on the Hastings Center website tomorrow.